Today, Thomas Budinger, who heads Berkeley Lab's Center for Functional Imaging, will discuss Berkeley Lab's rich history pioneering the field of nuclear medicine. Among his many accomplishments, Budinger's work led to the highest resolution PET scanner in the world, a 2.6 millimeter resolution camera, which was built in Berkeley Lab in 1986. Today, Budinger's group explores advanced PET and nuclear magnetic resonance imaging techniques, which are used to study cardiac function and brain disorders such as Alzheimer's and Parkinson's disease. Dr. Budinger is a medical doctor with a PhD in physics. In addition to his position at Berkeley Lab, he founded UC Berkeley's new bioengineering department and is a professor of radiology at UCSF. He is also a member of the National Academy of Engineering and the Institute of Medicine. He's also teaching a new course this year at UC Berkeley, Ethics in Science and Engineering, and recently published a book on this subject with his wife. And after his talk, we'll have time for a question and answer period, just like last Friday's lecture. Please wait for us to get you a microphone as we're taping this, and we want to get all the questions on tape. Please join me in welcoming Dr. Budinger.
Okay. Well, thank you for inviting me to probably the most critical audience that one could find in the world, and that is your own workers and colleagues who have watched the development of accelerator physics and chemistry, nuclear chemistry, toward a direction of doing some good for people other than having fun with science, that is doing some medical good. So there's so much to talk about. It took a long time to figure out how we could have fun and learn and get out before 1 o'clock with some questions. So I thought I would focus on two aspects mainly. And these were enabled by the discovery of the cyclotron, and therefore you have year 75, I guess, because that was announced in 1931 with E.O. Lawrence and Livingston, the inventors. So there's two major uses. One is to produce protons, deuterons, for purposes of generating radionuclides. We use the radionuclides then for investigating function of the body. So we hear the new term molecular imaging. We've been doing molecular imaging for over 50 years. And the molecules we image are molecules in the body as detected by radionuclide and their distributions. But the other part of our history that I think many know about and you would like to hear more about is the accelerator charged particles for pituitary radiosurgery, arteriovenous malformations, recently for treatment of prostate cancer, and also for cosmic particle science, a part of which will enable exploration to Moon and the Mars, and we'll learn about those. So first, 75 years. This would be boring, wouldn't it, if I went through every single one? Well, we're going to cover most of them, but I will not do a litany now. I present these highlights because they do represent some of the major aspects of discoveries, activities done principally between the years 1954 and the present. So that's 52 years of progress about which you're going to hear the highlights. So a good part of this started with John Lawrence. John Lawrence came to visit his brother. He was then at Yale working with Cushing and at the Peter Ben Brigham in Boston. And he interacted with his brother, E.O. Lawrence, at a time when it was pretty clear that things such as iron, body distribution was important for red cell kinetics, was important to situations known as polycythemia vera, which is an overabundance, like a cancer of the red cells, and leukemia. And he went back to the East Coast and found that was pretty boring compared to what could be done here, and returned in 1936. Through his influence, because he was an excellent entrepreneur, he convinced Joseph Donner, who's not a scientist, do donate the Donner Laboratory. And we see here a picture of Joseph Donner that still hangs in Donner Laboratory. And the reason I presented this was to show the intent, and that is for applications of physics, chemistry, and the natural sciences to biology and medicine. This is what Donner was all about. This is what it still is about 70 years later. So one of the first things that happened is that a fellow by the name of Joseph Hamilton, who was prone to do experiments on himself, mostly on himself as well as animals, asked Seaborg whether he could present an iodine, because we knew iodine was an important element in body metabolism that would have a few weeks half-life. So Glenn Seaborg and Jack Livingood focused on extracting iodine isotopes from the cyclotron then existent on the Berkeley campus. And here we see them in 1937 walking through a Sather Gate, which you'll recognize, to present their paper to physical review. That was the first iodine, and the first experiment done with the metabolism was in this child who had a goiter. And the experiment was to learn whether ingested iodine, so this is a pill swallowed with a radioactive iodine, not a serious radiation dose, to what extent that would accumulate in the thyroid and how it would change over a course of time. So if you take a pill of I-131 or any iodine, radioactive iodine, measure it before you eat it, and 24 hours later, measure the percent of the original that's in your thyroid, you'll have a measure of whether you're hyperthyroid. Most of my friends at LBL are hyperthyroid, I think. Most of my friends at Stanford, I think, are hypothyroid. So it's really the percent of the activity that was available that actually went to the organ. And this is a kind of the first principle, tracer principle, particularly if the tracer that you give is detectable from outside the body. And if you can measure the amount that appears over a period of time or at a particular time, the amount that appears divided by the amount that you had available, you'll have a measure of the activity of that organ. This is true, and you'll see for brain studies, heart studies, cancer studies, etc. So today, just today, I was on the telephone with somebody from the Department of Energy who said, what an outlandish claim that Berkeley had invented technetium, and most of the isotopes or the radionuclides that is a chemical, organic chemical compounds connected to technetium that have done good for mankind. Is this true? Today, only 3 hours ago. It is true. In 1938, Segre and Seaborg found technetium-99m, which is the most commonly used radionuclide in the world. Now, I wouldn't be boasting for them like this if it weren't for the fact that I don't think that we at LBL boast enough. Maybe it's because we aren't within an hour and a half of DC. We have some of the same initials in our titles. Okay. So how are some of these radionuclides produced, and why is the cyclotron so important? I just show one here, and that is for some of the students, the summer students that are here, would be interested to know how an atom smasher can make a radionuclide that's very helpful for women and men. So here's a proton, which is the nucleus out of a proton accelerated that slams into, in this case, oxygen-18. It's a non-radioactive isotope of oxygen. Recall oxygen-16. This is 18. And what happens is the proton goes in, knocks out a neutron, and we have fluorine-18, which is a 2-hour half-life positron emitter. Very important for studies, imaging studies, of the distribution of various compounds in the body. Here are the major compounds in yellow that were discovered at LBNL, LBL, AEC, and some of those in-between organizations, all having to do with the Atomic Energy Act. That is the establishment of this program. But even before that time, some of these date from the 1938s. Here's technetium, you can see, and the other elements. This is pretty amazing, isn't it? Because we're talking about carbon 11, carbon 14. So these are the radioactive nuclides, not the discovery of elements in the periodic table, but the discovery of the important radionuclides, that is radioactive isotopes, such as iron 59, not iron 56, but iron 59, iron 52, for example. Rubidium-82, one of the rubidiums comes from a precursor strontium, we'll see is an important radionuclide for studies of the heart. Well, once again, for some of those that have benefited from these items here, you would find this table interesting. For others, I would say that most of you in your lifetime will in fact have one or the other of these studies. And for example, it might not be I-131, it could be I-123 or I-124, also discovered here. So, for example, technetium bone scans. So we hear about somebody having a bone scan to check whether they have had disseminated cancer. Not only was a technetium discovered, but technetium latched on to a material called pyrophosphate. It's almost like toothpaste. In fact, I think you could put technetium-99m with toothpaste, dilute it a little bit, and inject it, and it would go to bone. It goes to bone as a function of bone blood flow. So it gets absorbed to bone just as you would expect some other thing that you've heard about. Let's see. He's sleeping. I'm not going to ask him. What do you expect if you had it radio-labeled would go to bone as a function of bone blood flow? Calcium. Calcium's a tough one to image, so. Fluorine, right? What about radio-labeled fluorine? So we didn't discover in those days how active fluorine, ionic fluoride, would go to bone, and you'll see in a moment what a fantastic diagnostic tool that is. So the Anger camera is something that we will emphasize along with other instruments, because we had to have instruments to go along with the nuclear chemistry that was prevalent at that time. We used to call it nuclear chemistry at this laboratory. Very strong group in nuclear chemistry. Transuranic elements were part of the interest, but also some of the lighter elements about which we're talking today. These were the various activities done in 1960s to detect where the isotopes go in the body, some of which have turned out to be very effective diagnostic tools. The scintillation camera, the positron emission tomograph, whole body scanners, tomographic scanners, even ways of measuring the distribution of an injected compound, let's say carbon-11 compound or carbon-14 even, 5,000-year half-life, but at 25 microcuries, not an important dose relative to the natural dose that you get from background activity and your radioactive potassium in your body. 25 microcuries would allow you to look at exhaled products from things such as methionine, which we learned is different in schizophrenia. It's pretty interesting. Could schizophrenia be a metabolic disease of the body, not just the brain? So these were the kinds of discoveries that were enabled by the radio tracers and techniques of measuring those radio tracers. I thought it would be interesting for you, some of you who knew Tony Sargent. I see Baird Whaley here. There he is. Now, Baird, did you have anything to do with finding the battleship steel that Tony?
I didn't. I knew about it.
So Tony Sargent went out in 1960 and found some, I think it was up to 16-inch thick plates from battleships, some parts from submarines, to put together a canister in which people would go and have something as simple as this photomultiplier tube connected to a crystal in the vicinity. So now I have a crystal called a scintillator. In comes the gamma rays, or out of the body come the gamma rays from, let's say, individuals exposed at Chernobyl. They hit the crystal makes a flash. We're going to talk about the crystals at the end. That flash of light is picked up by this photoelectron multiplier tube, and it registers based on the energy, the height of a peak. So it makes a spectrum from which one could detect fallout. One could detect, in fact, whether somebody had been in the vicinity of Chernobyl. So that was the last use of it, in fact, was in the 2 years after Chernobyl, to see if we could track those people that had been exposed and at the same time track where the radioactivity had gone. So this is very sensitive. Every one of us would have radioactivity that could be read in this giant chamber. Why was it so thick? It was to keep all the natural radiation out. And as some of you know, we have a fair amount of natural radiation in Berkeley. I know somebody will ask me afterwards, is it dangerous to live in Berkeley? It's dangerous, but not because of radiation. So here's a picture of the first Anger camera. It was invented in 1954. And I don't know, Bear, do you recognize this nurse? I recognize her. Yeah. And I don't recognize her, but this is somebody who we are very cautious about having our own patients involved here. So this is one of our staff. So this is an Anger camera. And this was a way of making an image. Instead of a Geiger counter measuring how many clicks there is over your thyroid, one could put together a series of these phototubes. Just imagine about 19 of these, or up to 54 of these things, all packed together in a giant circle. Now we have a plate. Instead of one little crystal scintillator, we have a big plate. Radiation comes up from, let's say, something injected that would normally go through the kidneys. You want to know if the left kidney and the right kidney both have the same kind of accumulation. So this is called functional imaging. Not MR, but with isotopes. So here's this plate, scintillator, only that thick, and the scintillation would come up through the back and hit the plate, making a light flash. Then having all of these phototubes around, you would detect where the light flash was by the intensity, the relative intensity in each phototube. I've made some beautiful drawings of this, but I think you make a point better if you can just imagine a whole series of phototubes and imagine the genius behind inventing such a machine and making it work. And that was the late Hal Anger, from whom apartment 3 days ago, Baird, I retrieved these phototubes. He was living in Berkeley. He had two apartments. One was to do more invention, and the other one was to sleep and eat. Very famous guy. You'll see a picture of him next. That's Hal Anger. And so instead of having a camera with phototubes finding the center of light, he had individual phototubes. This is like having 64 individual counters, individual Geiger counters, individual phototubes. And here you see this array of 4 lines of 16. Notice that they're offset. So if you integrate the information as the bed goes over the detectors, it acts as if there are 64 points to gather activity and present a picture of the whole body distribution. This is actually the first image, this image of the distribution of technetium in a patient who happens to have a tumor here. So there's some natural accumulation in the kidneys, there's some natural accumulation in bone and in bone inflammation, but this was the first detection of bone cancer using technetium pyrophosphate. Yukio Yano and Procter & Gamble have the joint patent on this, once again with this toothpaste kind of material, pyrophosphate. So many years later, we did studies with fluorine 18. This is a beautiful image of a skeleton. And John Ainsworth, do you think this patient is sick?
He's under full bladder.
Or what? Full bladder. That's right. So if I told you that this person was a left-handed tennis player, what would you think? Could be arthritis. And this could be either metastases or lumbar injury. So this patient has cervical injury, lumbar injuries, and was trying to play tennis, and not very well. As you can see, he was somewhat strained. He's still around, by the way. So I present this now as a different mode of using the discovered radionuclides. This happens to be an analog of glucose. And it goes into the heart as a function of how much blood flow there is to heart muscle. But also, it goes in based on what enzymes are active. So this is about the best example I can give of why nuclear medicine is molecular imaging, and it's imaging the activity of enzymes. Two enzymes are involved. One is the enzyme that turns the heart from liking glucose to liking lipids, and the other is an enzyme, hexokinase, that transports a glucose-like substance. And this is fluorodeoxyglucose being transported into the heart. So this is the same subject being investigated for cancer, did not have cancer, and you see here in the heart, post-exercise, non-fasted. Here he is fasted. So glucose was going into the heart because the heart wanted glucose after exercise, and it was available. Here he was at rest using lipids and not glucose. And then finally, I'd like to show an example of how nuclear medicine has enabled detection of distant metastases, but more importantly, how nuclear medicine can follow the efficacy of therapy. So this happens to be an image showing the whole body distribution of distant metastases from a breast cancer. This is after tamoxifen therapy. Tamoxifen, as some of you know, block the estrogen receptors, and it can be very effective in some cancers. And here the individual is post-chemotherapy. And we've studied this compound to see to what extent we could use these nuclear medicine techniques to decide whether therapy was going to work, was working, or in the case it wasn't, to be able to switch to other therapies. Well, many of you know that we're very interested in Alzheimer's disease here. Bob Friedland started the program here in 1979 and 80, followed by Bill Jagist, who spent some time here, went off to some other places, realized that much better back here, has recently come back to continue his program. He's been very successful in following Alzheimer's disease and in trying to ascertain something about mechanism and status of the disease. And here you see the distribution or lack of distribution of the glucose analog in these parts of the brain. All this tells us really is that glucose does not go into these parts of the brain. It doesn't tell us whether these parts of the brain are less than in the normal, or there's a hexokinase problem, a transport problem, or some other metabolic defect. So he's currently working on a large series of patients trying to detect things such as amyloid in the brain. So this is an old program that started in 80. Now we're 26 years later and maybe moving on to new ideas about the mechanism. John, you're one of the younger of the old people here, John Ainsworth. Still playing tennis, that's why. Do you know what causes Alzheimer's disease?
Amyloid. Build-up.
There we go, you see?
Newspaper.
So if I look at your scars on your body, and you couldn't move your hand very well because you had a scar. And you said, do you know what causes me not to be able to move very well? Well, I guess I could say scar tissue, right? I'm trying to make a relationship between some scarring, some consequence of Alzheimer's disease and the real cause. And it might be something other than amyloid. It might be inflammation. So I really believe that it is inflammation. How could we test that? We could look at people who are on anti-inflammatories versus people who are not on anti-inflammatories with some tracer that would show something about control of inflammation in the brain. This would have to be a long-term look because we'd have to look at many people over a long period of time, and then in the end ask who was demented and who wasn't. These studies are now underway around the world, and most people that are the amyloid enthusiasts will respond to the question that I answered. It might be amyloid, but it could be something else, and we're investigating it. And one way to investigate it is with these techniques. So let me move now to something that many people do not know about at this laboratory, certainly not at other laboratories, and DOE's completely forgotten it, and that is the use of charged particles for therapy. One of the early approaches pioneered by John Lawrence is pituitary radiosurgery. That is to ablate the pituitary without having any surgery and thereby control diseases such as acromegaly, Cushing's disease. So this is Cushing's disease, but also one could control parts of the brain function by ablating particular areas. So we did some studies in animals, not yet in brain, although you'll see a picture of one Parkinson's patient treated some time ago. Certainly arterial venous malformation. So this is bloodless surgery that is facilitated by having charged particles. What's so important about charged particles? Well, the physicist here would immediately recognize that this was pretty good, that he didn't get this part of the curve wrong. This is a charged particle going in, and when it slows down, it gives up most of its energy. So this, on this axis, is deposited energy, and on this axis is depth into tissue, whereas gamma rays, normal X-ray therapy, beta rays, and that is electrons, and neutrons have this kind of dose distribution. So you get cooked on the outside to get a little bit of dose into the tumor. The advantage of positron, of charged particles, is just shown here, that you can get most of the energy deposited in a particular region deep in the body. How big a region? Anyone want to guess? Pardon? Yeah. Absolutely. So some of the early studies were done on rabbit ears where you could actually see where the particle stopped by some line of necrosis. So here's a good example of, this is to show somebody in the beamline. It's an Apple PC compatibility again. But here is a vertebrae, and here's a spinal cord. Now, the idea is to miss the spinal cord by adjusting the energy so that most of the radiation would appear in this region for a tumor that was surrounding this part of the back. So you get the notion now that one can actually put in a particular energy and therefore control the depth, and up to a point, depths up to 10 centimeters or so, one can have a few millimeter energy deposition and protect the other tissues. Pretty exciting stuff. So here's how we line patients. This would be the human subject. You have some LINAC or some mode of injecting ions, accelerate the ions, and target the tissue very precisely. By very precisely, I mean within a millimeter. So we could actually train within a millimeter or even scan with millimeter accuracy, of course, the depth would be spread out a bit because they're scattering as the ion goes in. And you won't believe this. The people that know about hairdos will question it, but get ready for this result. This was one of the first studies done in acromegaly. So acromegaly is known as gigantism. And you see what I mean about having doubts? Well, she changed the color of her hair and her hairdo. Nevertheless, I can tell you unquestionably that this therapy of treating the pituitary, which is like surgical annihilation of the pituitary, results in an improvement of acromegaly, including facial features, heart size, lipid patterns, etc. So this is one of the first real successful radiosurgery, bloodless surgery attempts, and it was done by endocrinologists. I mean, although Lawrence was mostly a hematologist, well-trained in endocrinology, he had somebody by the name of Jack Linfoot working closely with him, who was an endocrinologist, and this was all done in the old Cowell Hospital. We had a whole floor there and saw patients regularly. So this was a great result. Another result was in Cushing's disease, which is an abnormal excretion of cortisone, etc., from the adrenal glands. But the reason it's abnormal is the pituitary is putting out chemicals to stimulate the adrenals. So if you treat the pituitary, you will solve the problem of Cushing's disease. And it works. But of course, you have to work closely with the neurosurgeons because they're the ones that see the patients. And so we evolved a program in collaboration, finally, with neurosurgeons. So this is a setup, the patient on a bed, careful alignment done by one of our investigators, John Lyman, who would allow us to get millimeter precision on this air table, very precise, and it was an amazing job of accurate pointing. Another disease that's a very tough disease to treat because of neurosurgical complications is arterial venous malformation. And that is when it's a congenital malformation where arterioles and venous form a basket of activity such as this. And what needs to be done is to ablate this area, that is to cut it out, tie it off. And one way to do that is to put in radiation so that it will sclerose and go from this to this without having to enter the skull. So this has been a very effective therapy practiced at Berkeley and now being practiced at Loma Linda. So all the activities that were underway here in the 70s and 80s are now being transported to other cyclotrons. There are 20 medical cyclotrons that can do this kind of work around the world. But with protons, not with the heavier ions that give a sharper peak. This is the use of nuclear medicine imaging to show the before and after for this kind of AV malformation. Once again, using nuclear medicine isotopes and cameras to show how efficacious the therapy has been. This brings us to some important activities that help create the Bevilac at this laboratory. At about this time that we were doing the AV malformations, Apollo 14 was underway, and one of the astronauts said to the other, I know these astronauts pretty well. This is Buzz Aldrin. Buzz Aldrin said, this is how he talks. You seen little white bullets? Shh. Have you? Shh. Well, they were afraid to say that they were seeing flashes of light because ground control would say they've gone a little wacky. Then word got out. Tobias was called by NASA. Tobias got together with me, and you'll see what happened. We believed, instead of these being, do you remember this, John? Some people thought that they were angels, lost souls that were trying to communicate. Physicists, not from this coast, but the other coast, thought it was Cherenkov, and the way to solve this was to turn your head toward the moon or away from it and see if the flash frequency changed. from Cherenkov radiation. So actually, the retina, as many of you know, is sitting facing toward the back, not the front in the eye. That's to start with. But the charged particles were charged particles, not of energy that would shrink. This is what they saw. They saw streaks, long streaks of light, some clouds, some little snow-like things, almost as if you're driving over one of the passes at night with your lights on and you see flurries of snow. How would I know that? These were the days that we very carefully filled out all of the forms. Jose Alonso will remember, because he put his finger on the switch that sent the ions down the tube. We filled out all the forms. It was before all the human use in IRB. It was before the laws. But we had our own forms, and Toby and I did the following experiment. So here's Tobias, late Cornelius Tobias. Great, very inventive Hungarian physicist who was a biophysicist as good as any in the world. And here he is again. And guess who this is? Can anyone recognize this? Anyone less than 50 years old recognize it? So this is Ed McMillan. Ed McMillan said, if you can show me that these charged particles really are the things that create light flashes, I will go to the mat for bringing the Bevatron back into life. So this was the experiment that had to do with connecting the connecting the LINAC to the Bevatron and moving it from position number 21 of importance to high energy physics to higher up. I don't know how high it got, but we got funded, and this lab is still here. So this was a critical experiment. This is the day it was done. The newspaper reporters wanted to know why we had suits on, how sure we were that this was going to happen. But before this experiment, this is the experiment with Tobias. He had this kind of go to the gallows mask on. It was to keep light out, because we knew that if it was charged particles, ionizing radiation, that you had to be dark adapted to see it well. So he was being dark adapted. We couldn't figure out how to keep the light out, so I took my belt off and put it around his neck. And here's John Lyman. Some of you recognize it. Here's what we saw. So we saw these kind of particles from neutrons. So what happens? Neutron goes in, just as if you're going to produce an isotope. It slams into carbon, nitrogen, oxygen, phosphorus in the natural tissues and causes something known as non-elastic scattering or spallation. So these nuclei kind of fall apart and make charged particles. Short range, but enough to give these phenomena in the eye, not the brain. Very exciting mechanism, still not. So what did we do? We had all these guys saying to shrink off, little fairies run around in the atmosphere. I mean, they were serious, that people were trying to communicate with the astronauts. And so we organized an experiment. This flew on the first Apollo Soyuz. We used the dark mass used to organize patients who were being treated for pituitary, put a light-emitting diode. Why? We wanted to calibrate how dark adapted they were, and flew the experiment so that the astronauts had this kind of orbit. Here they're a little bit closer to the magnetic pole, north magnetic pole. Through the South Atlantic anomaly, we expected them to see quite a lot. They were too low in altitude to see the hundreds of events that we expected. Here's what they call these events: hot dog, supernova. And we plotted these versus what we knew theoretically should be the distribution based on magnetic field lines, and it was perfect. So that was so much for that exciting experiment. And it was time to go on to say, are these ions dangerous to an astronaut traveling to the Mars and back? So in 2 years going to Mars and back, there will be about 3 million ions per square centimeter is the kind of fluence to expect. There will be about 3 hits each nucleus from a charged particle. Would that cause a problem? So Katie Brennan and I launched an experiment, lasted now 10 years, 8 years of one-time experiment. The last run, John, you had already left here, I think, the last run of the Bevilac, iron, day after Christmas, Katie, what date was it?
93.
92.
Yeah, we were going into 93 as they were shutting the doors.
We're second to the end, and it was like at midnight.
All right, so there we are. So then we followed these dogs for 8 years because the problem is latency, and then I had to sacrifice the animals to find if there's any effect. They had less amyloid, John, so maybe since you've been around a lot of heavy ions, you'll have less. So I want to quickly make a segue of where we've gone from those days to present. This is the earliest use of a proton beam to treat Parkinson's patients. This was not altogether that successful. It was not a big trial. But 40 years later, currently activities with UCSF and LBL, and I think Jamie, are you here? Jamie Eberlein is the leader of this program. We are doing a similar thing to charged particle therapy, but this is gene therapy using an injected gene to treat Parkinson's disease. And this is the first big therapy underway and supported by LBL, and actually imaging at LBL to see the efficacy of this therapy. So we inject a needed enzyme into these patients, and then we check with radioactive tracers whether the enzyme is working over periods of time. And here's one of a cartoon showing the images that one would have if there was normal activity in the brain for the dopamine system that we're investigating. And here's Parkinson's. And what you'd like to do is go from this Parkinson's kind of image to the normal. This happens to be a non-human primate experiment that was underway for about 5 years before we entered into human trials. My friends say don't show this, but after all, this is Berkeley, and I've seen a lot more dangerous things done. This is where we might go, the combination of positron tomography to see where the beam is going, because this beam is making positron emitters, so you can actually see where the radioactivity is going, and at the same time put a precise lesion into part of the brain that we think is responsible for a couple of diseases that are intractable: obsessive compulsive disease, depression. So if you have 5 years of intractable disease, that is, treatment doesn't work, terribly depressed, they keep you from going near the bridge, if they know that much about your depression, or obsessive compulsive disease, and I see some of us have this problem. It could be really bad, you know. People, I know a guy at DOE that wipes his face with his tie all the time. Geez, if I could only get him here, we could try something. So there's a particular part of the brain that's associated with obsessive compulsive disease, and we now have some ideas about using MRI to actually look at the white matter tracks, to look and find aberrations, and then precisely position a beam within 2 millimeters. So, and then we could see where it is. So I could get very excited about this possibility, and we've been thinking about a collaboration with Brookhaven to field an experiment in humans after doing appropriate number of animal studies. So nuclear medicine instrumentation, I've mentioned how important it was, and I'm not going to go through this laundry list except those of you that see the asterisks. The asterisks represent contributions made by Berkeley and supported principally by DOE, some supported by NIH. The first grants in this institution from NIH, in fact, were in support of the first positron, dynamic positron camera that Steve Dorenzo, Ron Huesman, John Cahoon, Tony Volicic, and I put together. It was the first NIH grant, and we're still struggling to continue to get more grants. So here's, gives you a notion now. See, you were napping before. Are you a chemist? I can already see by the look I'm not going to go there with you. So how is it that the positrons work? So a positron is a carbon-11 nucleus. Now he knows the carbon-12 is the normal nucleus. So what does it have? 6 protons, 6 neutrons. But if you do something to make an element that has less neutrons than protons, it doesn't like it, right? So there's a physicist here who would like to tell me which rule it is. I'm not sure if I should go and ask Turin or somebody. It's unstable. It doesn't like it. Okay. So what is one way to get more neutrons than protons? Have a proton become a neutron. If a proton becomes a neutron, what does it have to do? Lose a positive charge. That's the positron. So it's a positive electron. Now I made a presentation about carbon-11 at the physics colloquium. Louis Alvarez was sitting in the front row, and he said, "You'd be kicked out of here if you didn't show that neutrino." So here's the nucleus, and out come these photons. Now the photons come because this positron gets near an electron. So the students here would appreciate this. I know you don't all watch Star Trek, but there's matter and antimatter. And you have the Andromeda spacecraft and you got the Enterprise, matter and antimatter. When they get together, what happens? Poof. All of that matter goes into energy. How much energy? Well, E equals mc squared. So that energy will turn out to be 2 511 kilovolt photons. What's the normal X-ray? 70 to 120. So this is like 4 or 5 times more energetic than the normal X-ray that you might have. So here are these things back to back. That's fantastic, because if they're back to back, then you know that they came from something along that line, if you can detect that. So we won't go into all the details, except for one I'd like to tell you. Al Shepard and I became pretty good friends, and we were talking about doing some imaging of him. And he said, "Hey, bud, you mean to tell me that when these guys, when the positron and the electron get together, it's like an atom bomb?" Well, you got positive and negative, and they make energy, yeah. Well, how do you answer a patient who says that? Are these little atom bombs going off in my head? Okay, but the radiation dose is no more than what one gets for a usual study in 2 years of background in Berkeley. 1 year of background in Denver, Colorado. Okay, so let's move on. So here's the evolution of PET instruments. This is the first one built by Anger in 1954. Baird Whaley was involved in the administration of Donner Lab in those days and was sitting there with all of his money and his purse, etc., tied up in a safe because Hal would be knocking on the door for the next phototube, etc., to build his dual-headed gamma camera. Dual head because if you have these annihilation photons that are coming out like that, you want to get them in time coincidence so you can do a better job in making an image without having to put in place what we know as a collimator. So this has evolved now to multi-ring systems, and our own hopeful new system says 2008 plus. It used to say 2006 until OMB cut the medical applications budget, so I added a few years. And hopefully we'll have whole body systems that will take advantage of the isotope. So this is the evolution of improved volume. Here's where LBL stood in this evolution. This is a 180 crystal in 1980. It was the fastest system in those days. The 600 crystal in 1986 was not only the fastest, but the highest resolution, built principally by Tony Volicic, Steve Dorenzo, Ron Huesman, and others in the team. And this is the expected system someplace out here. You see this time gap has to do with OMB, and we expect to have 2 millimeter resolution for the brain with a sensitivity such that you could do child development. This is hard for people to believe, but when you show what sensitivity improvement can be made, show what the dose calculations are and the benefit to understanding chemical metabolism in children so that we understand better behavioral abnormalities. It'll be hard to buy, but the dose, the numbers are there. Okay. Here's the improvement of resolution, a different story. One is to get enough sensitivity, the other is enough resolution, and you can see this is our pattern in the center, 2.3 millimeter resolution, generally out a few centimeters, 2.6 millimeter resolution that was existent in 1986. So this is what most systems operate at now. This star pattern is what we can get. I know there's some physicists in here. I'd just like to make a point that they'll say, well, the positron range will kill you, not for all radionuclides. For fluorine-18 in particular, it's only 0.5 millimeter. And the components of resolution here, you see on the left. I don't think you want me to go through it, but I would like to emphasize to the physicists here that it is possible to get less than 2 millimeter resolution in a rather large machine, and it is possible to get 0.7 millimeter resolution in a small animal machine. And here's where LBL system stands relative to the rest of the world. This is for human, whole body or whole head PET, but this is the 0.7 millimeter University of Munster resolution that I had the opportunity to visit a few weeks ago. The detector development is key to improving this, and that's part of multi-purpose labs such as LBL, and I'd like to give you some ideas about how we're approaching the problem of getting 100,000 detectors around the body that will be able to be dealt with electronically and without too much scatter, and not to take too much time, but to make a point that this is like the retina, and this took 27 years of discussion to come to this device, and it all started one day with Steve Dorenzo and I running up Cardiac Hill. And thank God I stopped running a little bit after that, otherwise I wouldn't be here maybe. But Steve runs from here to Pinole regularly, and this had a lot to do with getting a silicon photodiode array that had a low enough dark current so that we could take the ratio of light for each one of these detectors. So here's hundreds of detectors around, each detector having 64 elements, to be able to control the electronics, and on top of that to do what we call time of flight imaging. So these little bombs going off, two of these gamma rays coming out, if you know when this arrived here versus when it arrived there, you can locate where the event was along the line. So you know where the line is because you've got a whole array of crystals around, and then you know where along the line it is. Perfect. You don't know exactly where, only within a few centimeters, but that's better than not knowing where it is at all along the line. That'll improve sensitivity, big factors. Factor of 5 in sensitivity by having time of flight. It's really something. People have been trying to do it since 1980 and just barely able to get there. I'd like to show you a camera that half of you would appreciate. The men, this is for the prostate. And so this is a new device that we built recently, and I will go on to try to conclude. How do you do the reconstruction? These were algorithms built at LBL. You think I'm trying to sell this institution? I'm trying to tell you how great a place it is that you've been working at, and how much fun that we've been having. So let me conclude by moving ahead so that we have time for some questions. and give you one of the hottest items in imaging, and that is it's good to have sensitivity, it's good to have detector capability, but it's also good to turn the lights out to see something. And one of our philosophies is to reduce the background. And how do you reduce the background? Better energy resolution, that means better crystals, better scintillators, and better chemistry. And I'll give you just some beautiful pictures of some chemistry underway. One kind of chemistry that really does molecular imaging to show gene expression. Scott Taylor, Henry Van Brocklin, and Jim O'Neill and others are involved in that. A method to see what kind of enzymes are on the surface of cells or in cells. Molecular imaging using radionuclides. And a way of improving the specificity by increasing or getting rid of, in effect, getting rid of contaminant like fluorine-19 contaminant when you make a fluorine-18 compound. This, I guess you'd have to say, you got to be modern, you got to call this nano. This is a nanoparticle, 27 nanometers. We deal with macromolecules that are 20 to 30 nanometers all the time. We never called it nano until we had a foundry here. And where are these crystals coming from? Isn't this a beautiful crystal? Steve, that's lead iodide, right? They're coming from trying to grow crystals, trying to compute what would be the best combination of elements. And here is one idea, a bismuth oxyhalide idea that Steve and his team have been working on. So these are the folks from whom I've taken some data, information, and appreciate their help in making this preparation. Thank you very much.